hope you can take away from the end of this session is to really list the common causes of neonatal thrombocytopenia and think a bit about their pathophysiology. Specifically, we'll look a little bit at the alloimmune thrombocytopenias. And then what I want to end with is the, are we okay? Okay. And to end with a look at the role of platelet transfusion and when and how should we be transfusing, because we actually, I didn't put this in here. We recently had a case that most of our group has been involved with of a very challenging newborn with thrombocytopenia, where all of these things have come up for discussion in terms of the etiology, whether or not it's an immune phenomenon, and what the role of the platelet transfusions would be. So before we can really talk about thrombocytopenia, I think it's always important to look at what the numbers mean. And this is a conversation I have all the time when I teach about platelets. So I think it's important to recognize a normal platelet count is anywhere between 150 to 450 times 10 to the 9th per liter. When we look at children, generally, even though 150 is the low end of normal, we typically don't call it thrombocytopenia until they're below 100. And when we look at the different levels, 50 would be the benchmark for trauma or surgery. Less than 20 is when we start to see the petechiae and some spontaneous bruising. And then at less than 10 is when we would be worried about a severe hemorrhage. The neonatal literature has a slightly higher threshold. Again, I think there's a lot of very good reasons for that, including things as more fragility of blood vessels and generally more fragility in your patients. So thrombocytopenia in neonates is anything less than the normal range, so less than 150. There are breakdowns, but probably what's most important as we think about the rest of this talk is less than 50 would be severe thrombocytopenia and less than 30 would be very severe thrombocytopenia. So that's my kind of look at the numbers. The next thing I always like to talk about with platelets is why a baby or a child is thrombocytopenic is as important as how low their number is, probably more important, in that the mechanism of their thrombocytopenia actually impacts their risk of bleeding. What we know is that the correlation between platelet count and bleeding symptoms is actually quite poor. So certainly in pediatric ITP, immune thrombocytopenia purpura, we know that the numbers don't actually count because the platelet count may be low, but these are healthy platelets that are being destroyed, as opposed to a patient with a bone marrow problem where these are unhealthy platelets that are small and not as effective. Specifically looking at newborns, there's a case series that I'll refer to a few times through the presentation, where they actually took a look at platelet counts, thrombocytopenia, and different bleeding symptoms, and they found no correlation with intraventricular hemorrhage, in contrast with a very high correlation with cutaneous symptoms. So the babies who had lower platelet counts had a much higher likelihood of cutaneous bleeding, but there was no correlation found with intraventricular hemorrhage, which, of course, in newborns and in older children, that's the bleed that worries us. So to kind of think of my first objective, look at the pathophysiology of thrombocytopenia. This is the list, and I'll show you the diagram in a second. There's some important considerations. So one is certainly pseudothrombocytopenia. In children, older infants and children, we can often see this from just it's a laboratory abnormality where the anticoagulant in the tube causes clumping. The more common thing I always see in the newborns with capillary blood sampling is small platelet clots under the lid. So we'll see a low platelet count because there's a clot in the tube that got missed under the lid of the capillary tube. One of the things I always liked about hematology, and I always kind of take all of hematology, you can break it down to when you have a low cell, you're either not making it or you're using it up. So all of hematology
Recording in progress.
We will focus a little bit on neonatal alloimmune thrombocytopenia. It's actually quite uncommon. And I suspect for those of you in the audience who work in the neonatal intensive care units, it doesn't surprise you that sepsis would cause thrombocytopenia and that we see it frequently. So, all of these conditions, which generally cause both peripheral consumption and some central production issues. Certainly any of these significant illness, you're not going to make your platelets, your bone marrow will be suppressed. So a whole variety of stuff. It's, for me as a hematologist who also has an interest in thrombosis, it's always interesting to find thrombosis kind of at the bottom of that list. So kind of looking at two of the big ones, prematurity and sepsis. The statistics from that case study were actually quite interesting. So they found the majority of the newborns with low platelets were premature. And these are the numbers that I kind of like. So the incidence of thrombocytopenia in all of the premature infants born in the study period was about 4%. So of all the premature infants born within the period of the study was 4%. But of the study population of infants with thrombocytopenia, 3/4 of them were premature. So certainly represents, the association between thrombocytopenia and prematurity. Associations that were important on the maternal side were maternal hypertension, preeclampsia, and immune disorders. And again, this kind of ties into other things where if mom has an autoimmune disorder that can be passed through the placenta, babies are more likely to end up with thrombocytopenia. And then, as I just showed you on the table, the most common newborn diagnosis of these thrombocytopenic cohort was sepsis. And they divided thrombocytopenia, just for the purposes of the cohort, into early and late onset, so within the first 72 hours or after that. And just under half of the early onset thrombocytopenia was sepsis. And as the babies got older, 3/4 of that was related to sepsis. And I think, again, that represents, when are you likely to acquire, when do the other problems happen that will cause thrombocytopenia? And certainly congenital things, alloimmune issues are going to happen very early on. Asphyxia is typically also at the early stages, whereas as you get later, sepsis becomes the more common associated diagnosis. So those are the causes of thrombocytopenia. The other thing is, what about the bleeding? So in the same case series, this is the bleeding symptoms that they saw. So about half of the patients who bled, it was atrioventricular, periventricular hemorrhage. Most of those were lower grade. There were very few of the severe type. 1/4 of them had cutaneous bleeding, and then a variety of other bleeding symptoms. So kind of a mix. Certainly IVH was common, although not severe forms of IVH. What they noticed, as in the commentary on the paper, is about 1/3 of newborns with thrombocytopenia will have bleeding symptoms. But as I mentioned before, when we look at the association between the platelet count and the serious bleeding symptoms, there isn't one. And there was an interesting suggestion that the thrombocytopenia that they see in association with intraventricular hemorrhage may actually be effect rather than cause, in that the babies had intraventricular hemorrhage, and in the course of recovery from that, they're consuming their platelets, so that the thrombocytopenia is an effect of the IVH rather than causing it. They did, when they looked in this case series at mortality, certainly the babies who had more bleeding symptoms had a higher mortality rate, but there wasn't a correlation between the actual number. And again, this is maybe an undercurrent of everything I'm saying, is that, when it comes to platelet counts, the numbers themselves are much less important than we often appreciate. I think we measure them, we can see them, we can follow them, we can treat them, but when it actually comes to the serious bleeding and life-threatening events associated with them, there isn't that correlation. So that's kind of the general look at thrombocytopenia, certainly prematurity and sepsis being the big ones. I do want to spend a few minutes looking specifically at immunologic thrombocytopenia and the FNAIT, so fetal and neonatal alloimmune thrombocytopenia. The statistics suggest this occurs about 1 in every 1,500 pregnancies. And I suspect many of you are fully aware that it's a mismatch in the human platelet antigen. I always teach this to residents and med students as the platelet version of Rh disease, because Rh disease is taught to everybody in medical school and NATE isn't. So, there's a mismatch where a paternal platelet antigen is foreign to the mother. Mom creates an antibody against paternal antigen, crosses the placenta, destroys the platelets in the baby. What we are learning more and more with FNAIT as well as all the other autoimmune thrombocytopenias is it isn't just peripheral platelet destruction. We are definitely seeing there's impaired platelet production. The antibodies have an impact on the megakaryocytes, on the platelet precursors in the marrow. So it is a combined problem, which is, again, where going back to the very beginning of what I started talking about, the nice, easy dichotomy of, impaired production versus increased consumption doesn't always hold for the immunologic. The big thing for NATE is this is thrombocytopenia with or without bleeding in a baby who's otherwise healthy. It's analogous to ITP in older children, where it is an isolated thrombocytopenia when there's nothing else to explain why the platelets are low. Again, when I teach this often as a comparator to RH disease, one of the big differences that I always stress is that this can happen on the first time. We don't need a previous sensitization event, a previous pregnancy. This may occur in utero, this may occur on the first pregnancy. So the first time you find out about this, maybe the first baby is born either with a bleed or with a significantly low platelet count. So, the question comes up, how do you diagnose it? And certainly this was a discussion we had with the case we had here recently in Winnipeg. And I've put this table up here, but I will say that for the most part, the diagnosis of NATE is a clinical diagnosis. So it's exactly what I just described, that you have isolated thrombocytopenia with or without bleeding in a baby who is otherwise well, and there's no other explanation. The laboratory testing is helpful if it's helpful. And I say that because two reasons. One of them is it takes a long time. So this is kind of the stage. This is a slide from Canadian Blood Services. Winnipeg, our center is actually the national reference lab for platelet testing. So the first thing they will do is a maternal human platelet antigen antibody screen. So they'll look to see, does mom have HPA antibodies at all? And if it's positive, then that's a presumed confirmation of NATE. But again, the turnaround time there is 3 days. Then you go into the more definitive tests. So genotype mom and dad, prove that they have a mismatch. That takes about 7 days. And while you're doing that, so MAPA is the gold standard test. This is a very technologically challenging test. It takes a long time in the lab. It will confirm that mom has an antibody that will attack the baby's platelets. It's a cross match, again, of maternal serum with paternal platelets, because we assume that there's the match there. Turnaround time of 14 days. So these are all very helpful. If they come back positive, they confirm that you've got NATE. However, by the time most of them come back positive, you're done, because you've already dealt with your low platelet count, you've given the interval management, you've watched their course, and it doesn't actually help you in the immediate management period. The other part of this is occasionally these come back negative, because you'll either miss the antibodies. We will typically start with the most common human platelet antigen types, so HPA-1A being the commonest one in the North American population, but that doesn't help you if it's one of the rarer types. So by the time you get the answers back, it's often too late to make a difference, because you've dealt with it. So how do you deal with it? Well, the question is, what's the risk to the babies? So, we know anywhere between 10 to 25% of newborns with neonatal alloimmune thrombocytopenia will develop intraventricular hemorrhage. Once again, there's no correlation between the degree of thrombocytopenia and the risk of IVH. Some interesting information coming out now that says it may be a combined effect. It may not just be the antibodies are destroying the platelets. The antibodies may have an impact on the platelets and the endothelial cells as well. So you have a low platelet count as well as endothelial disruption. So if you have an endothelial disruption, you have loss of integrity, you have a breakdown, it can't heal. That's where the intraventricular hemorrhage comes from. So it may be a combined effect. I think this pyramid kind of illustrates the important part, which is it is really, as much as ICH can be devastating and it's very concerning, it's the thing we're all worried about, it's actually very uncommon. So, 1 in 50 women will have an HPA-1A negative pregnancy. They're not all going to develop antibodies. So, less of them will develop the antibodies. So, but 1/8 of that 1 in 50 get the antibodies. Of that group, less than 1/3 of them are going to want to have severe thrombocytopenia. And of that group, about 1/8 of them are going to have to bleed. So for the whole population at risk, the likelihood of ICH is actually really quite uncommon. But of course, when it happens and it's devastating. So how do we manage neonatal alloimmune thrombocytopenia? It's an interesting thing as I was preparing for this. We all use IVIG. We all talk about IVIG. We know for NATE and for ITP, the mechanism of IVIG is unclear. There's some theory, the prevailing theory is that it basically occupies the reticuloendothelial system so that it ignores the antibody-coated platelets. The most recent guidelines, 2019, there were some international guidelines on the management of fetal and neonatal alloimmune thrombocytopenia. And they are actually specifically not recommending IVIG. They have made the recommendation that you shouldn't use IVIG, you should just move on to platelets because platelets work, they work quickly. So that guideline suggests that platelet transfusion should be given if there is life-threatening bleeding. And with a goal to maintain the platelet count above 50 for the first week, or in the absence of bleeding if the platelet count is less than 30. So if you're in that very severe thrombocytopenia range, you should give platelets. One of the big debates, I know we've had these discussions here in Winnipeg, is HPA matched or not. And the guidelines support the literature, which suggests that if you have HPA identical platelets, go for it. It's the ideal choice. But studies have shown fairly consistently that the platelet response is very similar with random donor platelets. So if you have access to HPA matched platelets, that is your best option. They will not be susceptible to the antibody. They will last a little longer. But the response to platelet transfusion is the same with random donor platelets, which are generally immediately available. So use the platelets you have available to you and use them early. And then the last part is the prevention of subsequent pregnancies. And I just want to share, this is a flow chart that came out of that the same study from the pyramid, which looks at what was your previous experience with FNAIT. And they suggest the worst case scenario, if you had fetal intracrine hemorrhage during the pregnancy, you should make a decision whether to either terminate or immediately start maternal IVIG. If you're high risk, so you had a previous sibling with a previous infant with a severe hemorrhage, you generally start your IVIG at around 12 to 16 weeks gestation. And if they call it standard risk, which is where they had the low platelets but no bleeding, then you can wait till about 20 weeks to start the weekly IVIG. This is a fairly standardized and acceptable that weekly IVIG is the best preventative measure. The question is kind of when do you start it? The more severe you are, the sooner you want to start it. So having moved on to that, the last thing I want to look at is platelet transfusion in the newborns in particular. So what they've noticed in case series and studies is that the decision to transfuse is often not based on the platelet count, but on the severity of illness. Again, going back to the common theme that the numbers don't tend to correlate with bleeding, is that there's really no evidence that correcting the platelet count itself impacts the bleeding events or the bleeding risk. The rest case series that I've talked about a few times found that actually the mortality rate was higher in babies who received more transfusions, but they commented that likely reflects a higher severity of general illness as opposed to actually more bleeding or more thrombocytopenia. So having said all of that, really we're left with expert consensus guidelines. There isn't an evidence to suggest what platelet count is safe. So typically it falls to similar to the FNAIT, is if you're less than 50 and bleeding, or if you're less than 20 to 30, you should just get platelets. And those are really, expert opinion rather than data, because we don't have the data. Why should we worry about the levels? Well, there are risks. Platelet transfusions are not without risk. So certainly the most simple risks are the transfusion reactions. So febrile transfusion reactions, allergic type transfusion reactions, fairly uncommon to actually see these in newborns because their immune system is fairly immature. TRALI is transfusion-related acute lung injury. It does happen in newborns, and it can often be very challenging because you have, you're transfusing a thrombocytopenic newborn who likely has other comorbidities, who likely has respiratory comorbidities, and now they develop increasing pulmonary infiltrates, hypoxia, respiratory distress. Is that related to the platelet transfusions, or is that related to their underlying illness? It can be very tricky to sort that out. TACO is transfusion-associated circulatory overload. I love transfusion medicine. They come up with some great acronyms. So this is just the fluid. There is a lot of fluid. The typical dose is about 10 to 20 mLs per kilo, but that can be a lot in a small baby, especially with other comorbidities. There is an infectious risk of platelets. Platelets are probably the highest risk for bacterial contamination, bacterial infection. And of course, long-term viral issues, less of a concern, but definitely the risk of bacterial contamination. And then finally, I put it in brackets here. It's always, whenever we talk about any transfusion, is the risk of alloimmunization. So, the risk of stimulating the baby to make an antibody. Again, pretty uncommon. It's always something we talk to families about, but it's one of those footnotes we talk to families about, because the likelihood of alloimmunization in a newborn is pretty slim. Their immune systems just aren't able to respond. So I wanted to just summarize. I know I've covered a whole lot in about 25 minutes, and I realized there's probably more I could have talked about. And so I've kind of covered things very quickly. But really, the kind of summary points, the take-home points is, prematurity and sepsis are the leading causes of newborns having low platelet counts. But also the big take-home for me always is that platelet count does not correlate well with bleeding symptom and risk. It is a number. It's a valuable number to consider, but it doesn't correlate directly to say what their risk of bleeding is. Transfusion thresholds are empiric thresholds. And really the most common reason for giving a blood transfusion is the severity of their underlying illness, whether or not they're bleeding. The sicker newborns with low platelet counts, even if they weren't bleeding, were more likely to get platelet transfusions. And kind of my last point, because I know this comes up all the time, is that while HLA matched platelets are nice, they're not actually necessary in fetal and neonatal alloimmune thrombocytopenia. If you have them, it's nice, but if you don't have them, use what you have, and you'll get as good a reaction. All right, and with that, I will say thank you. I found a picture of a platelet that said thank you. So thank you very much. I'm happy to answer any questions. Yeah, I will stop my screen sharing. There we go.
Thank you, Dr. Stoffman, for this nice, very interesting presentation. Any questions for anybody? Or can I start my first question?
Sure.
It's nice you have mentioned a short notice about trolley, which is very challenging problem actually. And we know it is more common with fresh frozen plasma, but also it can happen with platelet transfusion and packed RBCs. So can you tell us the main lines of treatment of trolley, and is it only supportive or any other treatment? And whether steroids is of value in this situation?
Yeah, that's a great question. I mean, the treatment of trolley is supportive. So, our best understanding of trolley is it's the antibodies. It's more common with plasma and platelets because of the plasma. It's the donor antibodies in the plasma reacting against the white cells of the recipient. So you get that hyperinflammatory reaction. And it's supportive treatment. I actually don't know the trolley literature well enough to know how helpful steroids would be. They're certainly good anti-inflammatories, so they're likely to have some role, but it is just supportive therapy. I know certainly if a trolley happens, it's something we report back. Our Canadian Blood Services will do a track back. They'll look at who the donor was. Certainly we know, multiparous female donors are much more likely to cause trolley in recipients. So for Canadian Blood Services, they will preferentially try and get, men to be plasma donors, because it's much less likely we're going to have all those extra antibodies floating around in our plasma. But it is supportive care when it happens. I think the challenge probably for most places, but NICU in particular, is spotting trolley, is realizing it's trolley and not some other cause of lung infiltration and respiratory distress.
Yes, very challenging and very difficult to inform the parents about what happened. Very, very, very difficult. Thank you. Any questions from the audience? Thank you very much, Dr. Stoffman. And we can move to the next speaker, Dr. Sameh. Thank you very much.
دكتور سلمى الحوشي حضرتك اونلاين مش كده؟ اتفضلي. حضرتك ميوتد.
I'm sorry. Yes, I'm Dr. Salma Al-Houshi, and I'm glad to present Dr. Narvi. He is the section head, the medical director of the medical child team, and he will be talking to us about the neonatal sepsis, a really challenging topic that we are all facing, especially in developing countries. Everyday problem to hear, and we're all here. Dr. Narvi?